Hello to everybody. I'm Federica Izzi, Product Manager of the BTS company. Welcome to this new clinical webinar on the NIRVANA, our immersive system based on the virtual reality for the motor and cognitive neurorehabilitation. Today, I'm here with the two special guests from one of the most important neurological hospitals in Italy, the Neurolesi Center of Messina in Sicily. Let me introduce you, Professor Rocco Salvatore Calabrò. He's a neurologist, clinical sexologist with a PhD in psychiatry, as well as head of the Advanced Laboratory of Robotics and Cognitive Rehabilitation. And the Dr. Rosaria De Luca. She's a therapist of psychiatric rehabilitation, specialist in cognitive sciences with a PhD in neurobiological and clinical sciences. Thanks a lot, doctors, to be here. And
Thank you.
I'd like to remind all participants that here in Italy, we celebrated last Saturday, the 24th November, the National Parkinson Disease Day. And BTS, which is always at the forefront to offer innovative solutions to better address this disease, wanted to join this initiative by organizing this clinical webinar. In fact, today our guests will show us their clinical experience on the role of virtual reality with the NIRVANA system in the rehabilitation of the patients with the Parkinson. The results that will be illustrated in this presentation are summarized in a recent publication in the Journal of Geriatric Psychiatry and Neurology. And thanks to the doctors, you have the possibility to download the PDF of this article from the document section in the panel on your right. Okay? So, doctors, thanks again to be here with us today, and you can start your presentation. Let's see later.
Okay. Hi to everyone, and thank you for the invitation. How you know Parkinson's disease can be considered as a neurodegenerative condition that is mainly associated with the depletion of dopamine-containing neurons in specific brain regions, including in basal ganglia. The disease has got a relatively high prevalence. Indeed, Parkinson's disease in industrialized country is around 0.3 in the general population and 1 to 3% in people older than 65 years. But the incidence is about 8 to 18 for 100,000 persons per year. So we know that the main symptoms are motor symptoms, and the diagnosis is mostly based on clinical signs. Indeed, the most important motor symptoms are tremor, stiffness, gait disturbance, and bradykinesia. However, we know that PD patient may also have cognitive and behavioral impairments with a consequent inability to participate in social and community life. Among the cognitive dysfunction, we have mainly dysfunction in attention and executive function, for example, in working memory, planning, inhibition, or set shifting. We have also problems in episodic memory, verbal fluency, or visual and spatial abilities. But at the same time, a patient with PD may have many important behavioral abnormalities, including anxiety and depression, and some problems concerning impulsive disorders. All of these worsen patient quality of life and, of course, increase the caregiving burden. So it seems clear that a multidisciplinary approach is fundamental in such kind of rehabilitation, indeed, to improve patient collaboration and treatment, and also, of course, outcomes. We need the rehabilitation of motor, cognitive, and behavioral abnormalities. And in this specific case, as we know that there is a really strict relationship between motor and cognitive system, the improvement in cognition led to better results also in motor performance. So when we approach a patient with problems in motor or cognitive function, we usually prefer to combine drugs with rehabilitation so to have better functional results. And when we use pharmacological treatment, we know that is also useful, this treatment, for the improvement of self-efficacy and emotional well-being. Generally speaking, cognitive rehabilitation can be considered a set of therapeutic activities that we use to reduce disability and improve quality of life in neurological disorders. And in clinical practice, we usually divide cognitive rehabilitation into restorative rehab that enables the person to develop the lost function through manual cognitive exercises, and also compensatory rehabilitation that helps the patient to improve the use of aids and tools so to overcome the impairment. And also in clinical practice, as in our study, we usually treat the patient by means of standard or non-standard treatment. For conventional treatment, indeed, we refer to the use of paper and pencil exercise with a face-to-face interaction, whereas when we use non-conventional treatment, we usually have the aid of PC-based or virtual reality tools. So why virtual reality works? Virtual reality works because this allows the user to experience and interact with a computer-generated environment by enhancing patient enjoyment and motivation. And above all, this is helpful because it's useful in simulating all those activities of daily life that are too dangerous to be performed in real life. During the rehabilitation in a virtual reality setting, usually our central nervous system is able to receive an increased feedback signals called augmented feedback that is really able to induce profound changes in neural plasticity. And such neuroplasticity appears because we think that, as in other neurological disorders, we can have a rebalance between the cholinergic and dopaminergic systems. And we have to point out also the important role of mirror neurons that we know offloads during the execution of the movement or during the examination of the movement that is performed by another individual, so to have the functional basis for functional recovery while we do a training in a virtual environment. And thanks to all this feature, we can say that virtual reality may have many advantages in the rehabilitation setting. Indeed, it is useful to simulate all those ecological life scenarios. We can recognize goal and performance thanks to the fact that the patient in a virtual environment is able to know the movement outcome, i.e. the knowledge of results, and also the quality of the movement, the knowledge of performance, so to improve and to potentiate the reinforcement learning that is otherwise improved thanks to the fact that this virtual reality environment increases patient motivation and interest. And we know that there is some evidence concerning the positive results of virtual reality used by a commercial wear system or specific designed tools for Parkinson's disease in improving motor performance with regard to balance, reduction of force, and gait, whereas only a few studies are addressing at the moment the role of virtual reality in cognitive and behavioral disorders. And this is the reason why we decided to start to plan a study concerning such kind of problems in patients with PD. So you can.
Okay. NIRVANA is a promising therapeutic virtual system using motor and cognitive rehabilitation of various neurological diseases. This tool creates virtual scenarios with which the patients interact, guided by the therapist in interactive training. So in a robotic and behavioral laboratory of IRCCS Neurolesi Bonino Pulejo, we have used the BTS and NIRVANA for cognitive rehabilitation of specific domains such as orientation, attention projects, memory abilities, executive projects, language and speech abilities, spatial cognition to modulate the psychosomatic anxiety. But now, how? Parkinson disease patients underwent an interactive virtual training in different scenarios with an augmented sensory feedback through the movement. In this picture, we can see that BTS NIRVANA included the infrared sensor, screen, video camera for recording, and PC controller. And this picture, there are some picture about our experience for the cognitive rehabilitation of patients with Parkinson's disease. So the aims of this study was to evaluate the effect of virtual reality cognitive training system and the cognitive and behavioral recovery of patients with PD. We have enrolled 12 patients with the diagnosis of PD, and in this pilot study, and randomized divided in two groups, 10 patients constituted the control groups and 10 patients the experimental groups. All the patients were evaluated by a specific clinical and psychometric battery before T0 and after the end of each treatment by T1. About the procedure, each cognitive training consists of 3 sessions a week, each lasting 6 minutes for 8 weeks, for a total of 24 sessions in both the groups. The inclusion criteria are diagnosis of PD according to the Movement Disorder Society Clinical Diagnostic Criteria for Parkinson's disease, Hohenheimer scale less than 3, present of mild to moderate cognitive impairment, mini-mental state examination from 11 to 26, and absence of disabling sensory alteration, such as audio-video loss. And exclusion criteria is age more than 85 years. And the presence of several medical and psychiatric illness potentially interfering with the virtual reality training. Primary outcome consists of the mini-mental state examination to assess the global cognitive state, and the group cognitive examination revised for detecting mild cognitive impairment, and in addition to administer the BILE test and the frontal assessment battery to evaluate the frontal skill abilities. And Hamilton Rating Scale for anxiety to assess the anxiety symptom, and the geriatric depression scale to investigate the mood. About cognitive traditional treatment, the standard cognitive traditional rehabilitation were administered in individual sessions with a face-to-face interaction between the patients and the therapist. Cognitive tasks were presented by using paper and pencil modality with proper paper aids. BTS NIRVANA is an innovative semi-immersive therapy system used for moderate cognitive rehabilitation of patients with neurological disease by creating virtual scenarios with which the patient may interact. Several models and increasing level of difficulty characterize each exercise. Concerning cognitive training, we included a series of exercises involving attention process, memory function, visuospatial cognition, speech abilities, problem solving, and executive functions. For the protocol use in our pilot study, the rehabilitation team established a series of baseline standard exercise with increasing difficulty, and the progression between the level of based on the patient's number of the heroes and the execution time of the activity. We can see in this picture a patient with PD while performing a cognitive task in a virtual reality environment. In particular, the storm screen of BTS NIRVANA allows to work on different domains based on the patient's abilities such as attention, spatio-temporal orientation, memory, language, and executive function according to the therapist's request. In fact, the patients indicated the object organized trip naming object. About the results, we have observed a significant improvement for the measure in relation to the FAB and the Vigo test only in the virtual reality therapy patients. We found a significant difference between the virtual reality therapy and the cognitive traditional training in the score relative to the global cognition functioning and those relative to visuospatial abilities. Regarding to the other subscale of the HR test, as well as the mini-mental state examination, we observed a significant improvement in the score of virtual reality therapy patients, while no significant interchange in the cognitive traditional training patient scored emerged. Regarding the mood evaluated with geriatric depression scale and Hamilton Rating Scale for anxiety, no significant difference were observed between T0 and T1 in both the virtual reality therapy and cognitive traditional therapy groups. And we can see in this table, as shown the table, in the HR scale between T0 and T1, the score of the patient and the virtual reality therapy tended to improve significantly, while of the cognitive traditional training tended to deteriorate significantly, as on the table. This is the first study demonstrating the potential role of BTS NIRVANA in improving cognitive recovery in subjects with PD. Our study showed that virtual reality could be effective in increasing global cognitive functioning in patients affected by PD. Our data demonstrated that virtual reality therapy can be useful in increasing the cognitive recovery in PD. In particular, we have observed an important improvement in the visuospatial and frontal skills. But future studies should be fostered in larger sample and with a longer follow-up. In conclusion, our results suggest that the BTS is a useful approach for the cognitive rehabilitation of the patient affected by Parkinson's disease. And this is the first study that have compared the conventional cognitive rehabilitation with virtual reality in the treatment of cognitive deficit in patients with Parkinson's disease. In our opinion, the funding we obtained are promising, as this suggests that virtual reality could be effective to improve the global cognitive function with regard to executive and visuospatial abilities, which are more compromising in patients with PD. Recently, we have realized a specialist cognitive manual of BTS NIRVANA task to stimulate specific cognitive domains such as spatial cognition, attention process, memory abilities, executive process, verbal fluency, language, perception, and coping strategies. In relation to the future direction about the use of NIRVANA in the treatment we believe in the use of NIRVANA in the treatment of attention process in autistic people, to treat executive process following traumatic brain injury, in particular in the frontal syndrome, and to treat, to stimulate the neglect post-stroke, and to modulate the severe anxiety post-stroke, and can be useful. It can be useful to the use in the sensory motor integration and aphasia, in the treatment of aphasia post-stroke. And the NIRVANA can be useful in the combined therapeutic approach of virtual reality with neuromodulation, DTCS and TMS. Thank you for your attention.
Thank you.
Very well. So thank you, doctors, for your great presentation. You illustrated very interesting findings. And thank you to all the participants for your time. So see you on the next clinical webinar.